Good morning, everyone. So I'm Michelle from Hong Kong, and today I'll be presenting my study on congenital thoracic malformations. So I have no conflict of interest to disclose. So congenital thoracic malformations are actually developmental lung lesions that include several subtypes, including the congenital pulmonary airway malformation, bronchopulmonary sequestration, bronchogenic cyst, congenital lobar emphysema, and also bronchial atresia. It occurs in 30 to 42 per 100,000 individuals per year. So amongst all congenital thoracic malformation, congenital pulmonary airway malformation is the most common subtype of CTM. And according to the Stoker classification, it can further be divided into 5 subtypes. Type 1 will be the most common type as shown in this table. And the typing is mainly characterized by different size of the cyst and the numbers of cysts found in the lesion. So we are very concerned about CTM or CPAM because there are studies showing that they have been associated with different lung tumors, including adenocarcinoma and squamous cell carcinoma. So, and another lung tumor that has been shown to be associated with CPAM will be the pleuropulmonary blastoma. So there have been ongoing controversies in the management approaches because there are great variety in presentations. Some or most of them present remains asymptomatic for a very long time, while some underwent malignant transformation. Therefore, as a result, there has been debate over whether these lesions should be conservatively managed or underwent a surgical intervention. The timing of surgery is also another area of debate concerning the risk of complications. So there has been a paper showing congenital lung formations, some unresolved issues and unanswered questions. In this paper, it had a flow chart showing whether and how to investigate towards this lesion, whether they are detected antenatally or postnatally, and how should they be managed. However, most of them are mainly overseas studies, and there had been no studies in Hong Kong on which one will be the best approach in managing these lesions. So this is also some of the flow charts shown by other studies that they should underwent some CT and X-ray at a certain age and to discuss surgeries. So this is another paper that studies it is a retrospective cohort study of 74 consecutive congenital lung malformation diagnosed antenatally over a 10-year period, and some of them or most of them are managed conservatively, remaining asymptomatic with a median time of 5 years. And another article was showing that 119 cases of children diagnosed with CPAM and managed conservatively with a median time of 9.9 years. And then some remains to be asymptomatic, or most of them. So the aim of our study is to determine the incidence, the clinical characteristics, the outcome, and the management option, as well as to develop some local guidelines and algorithms concerning patients to diagnose to have congenital lung thoracic malformations. It is a retrospective observational cross-sectional study in our department in Hong Kong. We retrieved data from our electronic medical records from 2002 to 2024. So patients with these diagnoses as shown here will be included in the studies. The diagnosis of congenital thoracic malformation will be confirmed by a CT. So those without a lung lesion on a CT after their birth will be excluded from this study. So we analyzed the baseline characteristics, including the age of diagnosis, their gender distribution, the CTM subtypes, the sites of lesion, as well as the lobe involvements in these patients. The primary outcomes will be the mortality rate of the patient, as well as the incidence of having pleuropulmonary blastoma or any lung malignancies. We'll also, for the secondary outcomes, we'll studied over the pulmonary morbidities, including chronic cough, pneumonia, hemoptysis, pleural effusion, and pneumothorax, the surgical operation rates and related complications, the number of CT performed before the surgery, or any pathological findings of the operated cases. Cases will be divided into two groups for analysis. One is the antenatally diagnosed group, which the CTM was diagnosed through antenatal ultrasound and confirmed by postnatal CT. Another group will be the postnatally diagnosed group, which they were diagnosed after birth and was not known antenatally. We've analyzed data in two categories. One is the continuous variables, including the age, the duration of follow-up, and which will be represented by the means with standard deviations or medians with their interquartile range. As for discrete variables, which includes the prevalence of various CTM subtypes, the incidence of pneumonia, operation rate, and the rate of operative complications, they will be presented as absolute counts and also percentages. So here comes the results. We have totally included 45 CTM cases. The AN group, there is 18 patients, and there are 27 patients in the postnatally diagnosed group. And there's slightly a male, the male to female patients is slightly equal. So the mean age of gestation is 22.4 weeks when they have their morphology scan done. As for the postnatally diagnosed group, the mean age of diagnosis would be 29 years old. The follow-up time for the AN group is 6.3 years, and for the PN group, it is 4.4 years. For the most common, for both groups, CPAM type 1 is the most commonest type for both lesions. And you can see the percentage distributions of the other subtypes of CTM. So all of them are unilateral lesions, and for CPAM, the most commonly involved group loops will be the right upper and right lower loop. As for bronchopulmonary sequestration, the left lower loop is the most commonly affected group. There was no death or malignancy in the antenatally diagnosed group. As for the postnatally diagnosed group, there were 2 deaths detected due to other diseases. That death case and 1 case in the PN group with extralobar pulmonary sequestration had lymphoepithelioma-like carcinoma diagnosed. As for the secondary outcome, the majority of them in both groups either presented as remains asymptomatic throughout the follow-up time or presented as an incidental finding during health checkups. The second most common morbidities that the groups of patients experience will be pneumonia. 1 patient had pneumothorax and 3 of them has hemoptysis. And for the antenatal group, 1 of them experienced respiratory failure due to the space-occupying effect of the lesions. For pneumonia, let's get to a more detailed analysis. In the AN group, the mean presentation of pneumonia is 4.5 years old, and 83.3% of them had a single episode of pneumonia, while 1 case amongst all had 5 pneumonias in total. As for the PN group, the mean age is much older. It is 18.2 years old, and 75% of them presented as a single episode, and 4 of them had recurrent pneumonia. 3 of them required chest drain insertion due to pleural effusion, and 1 due to large pneumothorax. 1 case required high-flow nasal cannula oxygen support due to respiratory failure. For the incidence of pneumonia, in the PN in the PN group, nearly all of them, which is 83.3% of them, will experience pneumonia. And also in the congenital lobar emphysema group, all of them had pneumonia in the end. So now, for the operation, both the AN group and PN group had a certain number of patients underwent operation with the lesion removed. In the AN group, 44% of them had operation, while in the PN group, there is 66.7%. The mean age of operation is 7.3 years old in AN group and a much older age, 34.2 years old in the PN group. The average number of CTs performed in the AN group is less than 2, while the PN group is 2.16. And 2 cases experienced post-operative complication in the AN group, and 4 cases experienced post-operative complications in the PN group, which both of them is mixed up around 1/4 of all of the operated cases. So amongst those having complications, one of them in the AN group has pneumothorax, which required chest drain reinsertion, while in the PN group, one of them has significant air leak requiring chest drain reinsertion, and 2 of them had significant bleeding requiring, one requiring thoracotomy, and another one, the bleeding was so severe that it caused cardiac arrest requiring intraoperative CPR, leaving the patient with long-term neurological sequelae. So now comes to our discussion. Our key findings is that the majority of patients with CTM mostly remained asymptomatic during the follow-up. And in the PN group, most of them also was presented as an incidental finding as a diagnosis, and more than half of them was diagnosed after adulthood, and there was a very low rate of malignancy. This indicated that CTM remained stable and clinically silent for quite a long period. Secondly, pneumonia was the most common pulmonary morbidity. Most of them presented as a single uncomplicated episode. There was a delayed onset of symptoms in the PN symptoms, as reflected by the PN group has a higher rate of pneumonia and also a higher recurrence rate. The infection risk in CTM is quite high because especially CPAM, as 83.3% of them developed pneumonia in the PN group. So this showed that since there was a delayed onset of the symptoms, these patients will require long-term follow-up, and it has a huge implication while counseling families and patients. So seeing these results, how would we manage patients diagnosed with CTM? We suggest that from this study, those with symptomatic, so those present to us with symptoms, surgery should be the definitive diagnosis because there were risks of recurrence, and which may lead to prolonged and multiple hospital stay. Elective surgery was recommended after the first pneumonia to prevent recurrence and further complications. As for asymptomatic patients, we think that there's a high risk that patient will subsequently develop pneumonia, as suggested from our results. And although there was no childhood malignancy in this cohort, but and we can also see that there has been possible severe complications in the surgery. Seeing to both the pros and cons of surgery, we think a more conservative approach, such as a surgery at a later age, will be appropriate in this group of patients. And the final decision of whether to conservatively manage or the timing of surgery requires discussion with the parents and the families. Another thing that brings out from this study is that the role of imaging. CT was very important in the diagnosis of CTM. However, repeated exposure to radiation, especially during the surveillance, will be a concern, especially in these pediatric groups. Therefore, in the future, MRI with radiation-free surveillance imaging will be recommended. Another thing is that some studies have showed a DICER gene mutation and KRAS mutation has a strong association with PPB and also CTM. So possible gene mutation will indicate increased risk of malignancy in patients also having CTM. So perhaps we can combine the genetic tests with the imaging to guide our management approaches. So there are some limitations in our study, as this is only a retrospective single-center study with a small sample size in its lack of lung function test data to support the long-term lung function of patients having CTMs. We hope that in the future, more prospective studies can be performed in different centers with the support of genetic tests and lung functions so as to have a more detailed algorithm for this group of patients. Thank you very much, and I welcome any question.
Здравствуйте, большое спасибо за предоставленную возможность выступить на международной конференции высокого уровня и доложить результаты нашей работы. Меня зовут Дмитрий Савельев, я врач-детский хирург клинической больницы Миротворцева города Саратов, а также ассистент кафедры СГМУ имени Разумовского. А это мой переводчик Юдина Анастасия, также врач-детский хирург клинической больницы имени Миротворцева.
Hello, thank you so much for opportunity to speak at a high-level international conference to present to your attention the results of our works. My name is Dmitry Savelyev. I'm a pediatric surgeon at Miratortsev Clinical Hospital in Saratov as assistant at the Department of Pediatric Surgery at Razumovsky State Medical University. This is my translator, Anastasia Yudina, a pediatric surgery at the Miratortsev Clinical Hospital in Saratov too.
Рубец – это неизбежный исход травматизации кожного покрова во время оперативного вмешательства. Он является немаловажной составляющей удовлетворенностью общего впечатления после перенесенного вмешательства в любом возрасте. А клинический исход рубцовых изменений разнообразен от еле заметных линий до больших килоидных травмирующих рубцов. И от этого зависит как уровень комфорта пациента, его качество жизни, так и возможная тактика лечения.
Scarring is the inevitable outcome of skin trauma after surgical interventional. Scar is an important component of satisfaction with surgical treatment at any age. The clinical outcome of scarring of the skin can take various forms, from barely noticeable whitish lines to the formation of keloid scars. Both the patient's comfort level and possible treatment tactics depend on the type of scar.
Именно поэтому кожный рубец должен быть подвержен систематизации и оценке на разных этапах своего формирования, как с количественных позиций, так и с учетом субъективного восприятия ребенка.
That is why scars should be systematized and evaluated at various stages of their formation, both quantitatively and subjectively.
На сегодня в мире существует по меньшей мере 10 шкал оценки кожных рубцов, и несмотря на их многообразие, все еще не существовало специализированного инструмента для оценки у детей. И поэтому нашей целью закономерно стало создание первого инструмента оценки кожного рубца у ребенка. Он должен был учитывать требования клинометрии, возрастные и психологические особенности ребенка, быть простым в понимании и администрировании и интерпретации результатов.
The aim is to develop a new tool that can assess the scars on children's skins. It should take into account a requirement of clinometry, age, and psychological characteristics of the child, be simple to understand and complete, and be fast in interpreting the results.
На разных этапах нашего исследования в общей сложности приняло участие порядка 170 пациентов, детей. И критериями включения в исследование являлись наличие кожного рубца, срок от момента перенесенного вмешательства более 1 года, то есть зрелый рубец, возраст ребенка от 7 до 17 лет, и период исследования составил 2021-2024 год.
A total of 117 children participated in different stages of the development and validation of the questionnaire scale in the study. The inclusion criteria were the presence of a skin scar acquired as a result of the surgery, the period from the moment of surgery is more than a year, age between 7 and 17 years, consent to participate in the study. The study period is from 2021 to 2024.
Были проведены процедуры эксплураторного факторного анализа, множественного регрессионного анализа и с учетом всех необходимых для этого критериев. В качестве статистического критерия сравнения результатов между собой был выбран критерий Спирмана.
The procedures of exploratory factor analysis and multiply regression analysis were carried out, taking into account all the standard criteria necessary for this. Spearman's criterion was chosen as a statistical criterion for comparing sets with each other.
В разработке инструмента принимали участие не только врачи, но и педагоги профессиональные, а также детские психологи.
Not only doctors and also child psychologists and teachers took part in the development of a tool for subjective assessment of a child's scar.
А в основе была заложена теория возрастной периодизации известного русского психолога Льва Семеновича Выгодского. Она подразумевает деление периода жизни ребенка на 3 периода. Это детство 7-10 лет, отрочество 11-14 лет, юность 14-17 лет. И в каждом из этих возрастных периодов для ребенка важен ближний человек – родитель, одноклассник, ровесник.
It based on the theory of the age periodization by the famous Russian child psychologist Vygotsky. It involves dividing into 3 life periods: childhood between 7 and 10 years, adolescence between 11-14 years, and youth between 14-17 years. In each of these age periods, a neighbor is an important to a child, a parent, a classmate, a peer.
Таким образом, визуально-ассоциативная педиатрическая шкала субъективного восприятия рубца представляет собой 3 листа с вопросами. Каждый из них предназначен для последовательного заполнения врачом, ребенком и родителем.
Subjective pediatric assessment scale consists of 3 pages with questions. 1 page for each side for the study, for the child, for the parents, for the doctors.
Листы опросника для детей разделены в зависимости от возрастной периодизации. Средний уровень межэкспертной надежности был высоким и составил 96 сотых. Внутриэкспертная надежность имела вероятность от 0,85 до 0,96. Совокупное значение конвергентной валидности было прекрасным и приближалось к единице, а общий уровень Алька-Кромбаха опросника составил 0,83.
The questionnaire page for children are divided depending on the age periodization. The average level of inter-expert reliability among doctors was 0.96. Inter-expert reliability had a variation from 0.85 to 0.97. The cumulative convergent value for the questionnaire was 0.95. The total Cronbach's alpha level for the data obtained among parents was 0.83.
Таким образом, общая субъективная оценка кожного рубца ребенком значимо и положительно коррелировала со следующими показателями. Это социальные аспекты наличия рубца, физические неудобства, вызванные наличием рубца, а также проблемы эстетики и лечения.
The overall subjective assessment of a skin scar significantly correlates positively with the following indicators: social aspect of presence of a scar, physical, aesthetic, and problem of aesthetic and treatment.
Вопросы в каждом листе оценки, как для родителя, ребенка и врача, имеют различную синтактическую формулировку, однако они объединены по смыслу и соответствуют выделенной ранее факторной структуре.
The questions on each page have different syntactic formulation, but are united in meaning and correspond to the selected factor structure.
Таким образом, визуально-ассоциативная педиатрическая шкала оценки кожного рубца, SPASS, первый инструмент подобного рода для применения среди детей, и среди многообразия различных мнений о значимости наличия рубца сформированы группы наиболее важных предикторов, и при помощи факторного анализа они разделены. Высокий уровень внутриэкспертной и межэкспертной надежности опросника для врача проверен на практике среди врачей различных специальностей. Опросник адаптирован для детей различных возрастов с учетом периодизации психического развития. Шкала может быть использована как очно, так и по фотографиям или в сети интернет.
Subjective Pediatric Assessment Scar Scale is the first tool of its kind to be used among children. The questionnaire is adapted for children of different age, taking into account the periodization of mental development, the inclusion of the opinion of a doctor and a patient and a parent in the scale is innovative and allows us to most fully determine the subjective attitude to a skin scar in a child.
Можно попросить вниз повернуть постер, прокрутить, пожалуйста. Хочу отметить, что на данный момент первые инструменты, разработанные для оценки рубцов, доступны только на русском языке. Однако мы готовы к проведению исследований и кросс-культуральной адаптации на любой язык. Ближайшим аналогом является шкала SPASS, которая была разработана в Голландии. Внизу расположен QR-код, который активен. С удовольствием отвечу на все вопросы и почту для связи предоставлю в общий чат.
Can you show the last part of the poster?
Please. Ну ладно.
Okay, now PASS available only Russian language, but we are ready cross-cultural adaptation. Detail on the QR code, or I leave my emails on a common chat.
Yes.
Thank you.
У нас все, спасибо.
Thank you for attention.
Morning for all. I am Dr. Lai Aburayan from Palestine. I am a PhD in nursing, child health and disease. I'm a graduate from Near East University. Now I'm working at Palestinian Polytechnic University at Nursing College as a lecturer. Today I would like to talk about a case report, my published paper, case report, an investigation, the application of Orem self-care nursing theory for spinal muscular atrophy. It was a case study design.
Dr. Loai,
Yes.
sorry to interrupt. Could you please enable the slideshow mode?
Is it okay?
Yeah, perfect.
Is it change the slide?
Yes, it's
Okay, thank you. First of all, I would like to start with a case summary. In this case report, according to Orem self-care deficit theory, data on 3-year-old and 9-month-old boy patient who was admitted to the pediatric ICU and diagnosed with SMA type 1 SMA Warding-Hoffmann disease, which is characterized by delayed motor, milestone, and progressive muscle weakness, failure to thrive, and compromised respiratory function. And it's characterized by poor feeding, difficult swallowing, poor reflux, and risk for aspiration. The child parents are actively involved in their son's care and are seeking guidance to improve their understanding of SMA management and enhance their self-care abilities. What is SMA? SMA is a neuromuscular disorder that is highly frequented in children. There is 4 types of SMA. This leads to a serious health challenges for children of different severity level. Orem's self-care deficit nursing theory help parents get involved in their child care, leading to better outcome and healthcare experiences. Accordingly, this case study examined the effectiveness of applying the Orem's self-care theory for the nursing to child with SMA and his parents. It's helped the nurses to manage and care with this patient. Spinal muscular atrophy is one of the most relevant neuromuscular disorder or disease in children and has a high morbidity and mortality rate for children. And most of SMA child were died. Infant mortality due to genetics is the most common, accounting for 1 in 10,000 live births, with a global prevalence of between 1 to 2 per 100,000 people. For the case, there are deficiencies relating to mobility, eating, swallowing, and respiratory function in a 3-year-old child. We recognize the patient's lack of self-care and created a tailored plan for self-management training. The initial steps were to understand the patient needs, organize the implementation, and create the educational system. And the final phase entailed implementing the self-care program and assessing its success. The study methodology. The following methods were used to gather the data. First, structural interview and surveys on Orem's theory and self-care ability. A 60 minutes educational intervention was divided into 4 in-person sessions with patient and family. This study illustrates the useful application of the theories in illness management. This theory was used to identify deficiencies in movement, feeding, swallowing, and respiratory function and management for the family and patient. Nursing interventions focused on neuromuscular deficit, while educational interventions enhanced parent awareness. The intervention, the first step is to know the client and parents' needs to determine what kind of nursing care the person needs. The second stage is the design of supporting educational system and planning for the implementation of care. The third step is the implementation of the self-care program and evaluation the program implementation for this patient. The main result for this paper, Table 1, patient basic condition and factors. The patient age 3 years and 9 months old. Gender, he is a boy. State of development, preschool age, and state of health, type 1 SMA. Cardiac echo was free, the last cardiac echo. Laboratory result during the last admission to our pediatric ICU, sorry, pH 7.4 and UNGAP 14, hemoglobin 11 with normal kidney function test and electrolyte. CRB was 45, but the blood culture and urine culture was negative. For the medication, the patient was started on Miranon vancomycin, epagliflozin, baclofen, and phenobarbital. Already, he take this medication as anticonvulsant, some anticonvulsant, blah, blah, at home. Health impression, the health situation was rated as low with a poor prognosis, hopeless case. For the family system variable, the family is extended, the grandfather, grandmother, parents and brother are living together in the home. Style of living: the child did not consume alcohol, drug, or smoke because the patient was still a child. His father did not take alcohol or drugs. He is a smoker, and his mother did not smoke. The child cannot perform any activity due to her medical condition. Environmental variable: he resides in an apartment complex on the first floor of the building. Availability and sufficiency of resources. He experienced a lot of financial problem because his father was obligated to buy a portable mechanical ventilator and suction machine. In addition, the child needs frequent admission to the pediatric intensive care unit, which require considerable money. However, these cases are financially supported by the Palestinian governmental Ministry of Health, which support him through medications and supplies he needs for treatment, and they support during admission for pediatric ICU or to the hospital. Table number 2, the medical self-care requirements, patient self-care deficit, and universal self-care requirement. For self-care deficit and developmental self-care requirement, the first point, preserving and protecting the environment for development. For this family, he went in for a checkup every year to prevent further cases and decrease of the risk factors. For the health disturbances, self-care needs, and the self-care gap, locating and securing stable medical help. For therapy and testing, he went to the facilities or hospital with internal medicine or specialist when he was ill, and no problem for that. Understanding sick illness, effects and consequences, and being prepared for them. No contact could be made with the patient. His mother was unaware of a problem caused by a safe feeding practices and sign of aspiration, motor function, nutrition, and respiratory status. Self-care deficit: insufficient information on the impact and outcome of the disease condition. Recognizing planning for the effect of medical care, modifying one's concept of the perception on self in certain condition of health. His parent tried to manipulate his SMA and had no problem with it. Learning to cope with harmful effects, no problem for the family of this patient. Table number 3, we talk about session activities and topics for this case. The first session about introduction, about SMA, what is SMA, definition, causes, type, blah, blah, blah. The activities: understanding SMA, experiencing, reach, and defining SMA, explaining the causes, type, symptoms, and diagnosis of SMA, and discuss the complication with the family about this disease. And the family, they are know a lot about her case because it's not the first baby within this family with SMA. The second topic was adaptive strategies for mobility and independences in the daily activities, assistive devices, and technology for SMA patient, technologies for maintaining good posture and preventing muscle contracture, discussing on respiratory care, including breathing exercise and the use of respiratory devices. Tip for optimizing energy conservation and managing fatigue. The activities were managing daily life with SMA, answering the past question from the family, providing an overview of SMA, discussing better control of SMA. For the third topic about nutritional, about the maintaining a healthy weight, we try to maintain the patient weight, discussing the importances of proper hydration and feeding, how to consult the dietitian, the nutrition and SMA, discussing important issue regarding nutrition and exercises for SMA patients. The fourth session about coping strategy from the family and emotional challenges associated with SMA, addressing the social and psychological support for this family, encouraging self-advocacy and empowering SMA patients to voice their needs and concern. We use activity of psychological and emotional well-being for those families. Understanding the benefits of exercise for SMA patients, tailoring the exercise program to individual abilities and limitations, introduction to adaptive exercise and technique for maintaining muscle strength and flexibility, using through the activity of adaptive exercise and physical therapy, and answering the past question for this family. The last topic is exploring assistive technology option for communication, mobility, and daily living tasks, introduction to accessibility features in the environment, home modifications, and adaptive equipment, collaboration, and addressing financial resources and assistance program for acquiring assistive technology. Assistive technology and accessibility, try to summarizing the contents of the session and presenting public. In conclusion, finally, the conclusion, this study provides a valuable insight into applying nursing theory in pediatric nursing practices, particularly in managing SMA, by leveraging a theoretical framework like Orem self-care deficit nurses theory. Nurses can play a vital role in promoting self-care, independence, and improving outcome for children with SMA and their families. Thank you for your listening. Any question?